Good evening, everybody. I'm Dr. Ralia Bashwa, and I have Dr. Kelsey Steele with me today. And we're just going to be talking to you about sex. We were trying to get some intro music for this piece, but I think we couldn't get it. Just to get us into the mood and talking about something that is pretty much on all our minds anyway. So I thought before we just started this, we just talk a little bit about definitions and remind ourselves of what menopause is and the perimenopause period and the postmenopause period. And so menopause is a retrospective definition, actually. It's 12 months after your last menstrual period. So after you've gone 12 months without a period, then we say you've had menopause. And in this conversation and dialogue tonight, I will be using women, but I do recognize and acknowledge that not all persons with uteri are women, and not all women identify, but not all women have uteri. So please bear with me. So perimenopause is a transition time from before menopause begins to that final 12 months and the 12 months after, and that can last a very number of years. And postmenopause will be sort of after you've had, the 12 months of no periods, then we see the postmenopausal time. And there's a lot of physical signs that go on with the menopause, common things that you might remember or you might be going through right now: the hot flushes, sweats, difficulty sleeping, feeling like your brain is in a bit of a fog, your memory isn't the same. And some of the symptoms that we go through in this time, some of them are, due to menopause, and some of them are just due to sort of aging itself. And in the perimenopause period, particularly at that time, your hormone levels fluctuate a lot and become unstable and unpredictable. When they're high, you can have some bloating, breast tenderness, and bleeding, the perimenopause period. And when you have low estrogen levels, you can have hot flushes, the sweats we spoke about, palpitations, headaches, insomnia, fatigue, dryness, and bone loss. The other hormones that we have in our body, that's mostly the effects of estrogen. We have testosterone as well, and we have progesterone, okay? Progesterone really regulates bleeding and affects bleeding pattern. And typically the production of that stops when you have your final menstrual period. And testosterone is mostly thought of as a male hormone. It has a key role in estrogen production. It contributes to libido, bone mass, and muscle mass. And it declines slowly, by menopause, you're about half your peak, than when you were in your 20s. Your ovaries continue to make testosterone even after they stop making estrogen. So it's sort of a more age-related decline rather than menopause. We're just going to talk about some of the changes now that happens to our bodies when we go through the perimenopause and the menopause period. One of the big changes, particularly as it leads to our topic on sex tonight, are the changes that happen in our vagina and our vulva. So just a quick collection that the vulva are the outer bits of a genitalia that you can see, and the vagina is the inner bit, okay? So less estrogen can cause the tissues in the vagina and the vulva to become thinner, they become dry, become less elastic or flexible. You have less secretions, that leads to less lubrication, and they make it less acidic. It kind of goes back to your pre-pubertal tissues, so tissues of young girls, as it were. I have a little diagram up there, and if you see the picture on the left, so the one with the divots and the folds, and that's the pre-menopausal vaginal tissue. And the rugae folds allow it to swell and expand during childbirth and during sex. So there's stretch, there's flexibility in that. And the postmenopausal period, you lose all that so that the vagina is not as elastic, it's not as flexible, okay? So, like I said, the vagina becomes shorter and narrower. Sex can get painful, even with lubrication. And because this tissue is just dry and fragile, you can have inflammation and infection of the vagina and vulva. Other changes that we notice in the perimenopause and menopausal period, we notice breast changes, our skin can lose elasticity, your hair can change. For some people's hair loss, some people get a little bit of a stubble and a bit more hair in certain places. our body composition changes as well. We've got to go from a more pear-shaped weight distribution to more apple-shaped weight distribution. Menopause isn't thought to cause weight gain in pregnancy, but can affect, like I said, the weight composition, so that you shift your focus from weight in your, thighs and your bottom to sort of like your belly area. So what is normal? What is normal sex? I think that's the first question on our minds. And Dr. Steele, I think, can provide us with, Dr. Steele, what is normal sex? What is a healthy sex life?
Oh, that is such a loaded question. And the answer really is that it depends on the person. And so, oftentimes I get a lot of people that come in and say, we were having sex, every night when we were first together, and now it's once a month or not even once a month. And so for them, that's a really big change. That's not normal anymore, right? But realistically, what happens is that sex is on a spectrum. It's going to ebb and flow throughout our life, and how we feel about those ebb and flows will really determine too how often we engage, most likely. Okay. Other things that come into play can be relationship dynamics. Do we have a good relationship with our partner? Do we have good communication with our partner? Not just everyday communication about, who's going to what place or what do we want for dinner, but also sexual communication. A lot of times people are afraid to talk about what feels good and what feels pleasurable, or what doesn't feel good and what they don't want. Sometimes there can be a lot of discomfort about that. Also, it can really depend on, obviously, body types, right? Or changes in your body. So with that ebb and flow, let's say that lubrication really comes down and people might not feel comfortable using types of lubrication, or don't know where to start to even find lubrication. And so sometimes that can really impact and change a sense of normalcy with sex life, due to their range of knowledge or even who to ask. If there's any participants that feel comfortable sharing, what would you consider as normal, or things that might change over time? You can put it in the chat. We really encourage you to participate so that it can be a little bit more interactive. Does anybody have anything that they'd want to put or feel comfortable? We'll give it just a few seconds. As people kind of think about that or determine if they want to share, what we also know can be normal, which is what we call the sexual response cycle, and I believe you're going to go over that in just a few minutes, is that within a cycle itself, is that everybody will have a sense of desire, arousal, then orgasm, and then that resolution. Okay. Now that is a normal response, meaning our body goes from a plateaued, unaroused state to feeling desired to up, maybe reaching orgasm or some type of satisfaction, right? Not every sexual experience is gonna be complete with an orgasm, and that's also normal. That's okay, unless it causes distress. But a lot of times people say, that's really satisfactory. That feels good. Oh, let me see here. It says that the chat is disabled.
It is the Q&A that we need our participants to use.
Q&A, okay. Are you able to use the Q&A for anybody that feels comfortable? That is my apologies. Okay, so somebody had mentioned in the Q&A that desire and whether it increases or decreases over time. This is such a great question, and research shows that individuals that go through menopause historically have had really negative perceptions about what that's going to be like. And when we have those negative cognitions, what can happen is that it can actually cause that to decrease. And so we're not actually paying attention to our body and the cues and arousal cues when there is actual arousal. It's not uncommon for people who do experience, maybe there's not as much disruption in lubrication, or there are healthy dynamics for that to actually increase. A lot of women say that they feel good. Some of the consequences with not having, pregnancies and things like that can also increase that desire and libido, because now it's kind of off the table, if you will.
Exactly.
Okay, and some are expressing that it can decrease, which absolutely it can. And so we're going to talk a little bit about treatments and different things to consider. So as we go through the presentation, kind of think about if any of those things ring true in terms of if you are experiencing some of that decrease. Feeling desire. I hear this one all the time with my clients. Feeling desire to have sex is also kind of what we're going to talk about too, because it is something that can be worked through based on, starting a conversation early with your significant other to kind of get you in the mood, or feeling comfortable of things to integrate so that it feels satisfactory and pleasurable. We do not want to have sex while we're in the middle of thinking about getting the groceries and cooking dinner. That's not ideal time. Okay, so it looks like there is definitely a lot about desire. So I hope that this is something that is, that we can clarify and really talk about. If anybody has specific questions, we can definitely do that and go through those.
I'll just keep talking about a bit more about desire and some of the questions as they're coming up, and we'll keep Dr. Steele keep an eye on the chat on the question box, but please put your questions. We want this to be interactive. I must confess, I've never met a sex therapist in my life. Dr. Steele is my very first sex therapist that I've met and have worked with, and she's amazing. So I do really encourage you to take advantage of this wonderful opportunity to ask all those questions you've always wondered. What is a sex therapist? And I think she'll talk a bit more about that later as well too. So we just go into, so as she's spoken about, we do have desire, arousal, orgasm, and resolution. And so desire, it can be thought about sort of that, in terms of the desire to have sex, and it's made up of like the drive, the biological component, your sex thoughts, the fantasies, erotic attraction, your genital tingling. And she's sort of spoken about how this can vary from woman to woman, from day to day, from activity to activity. Desire is driven by drive, motivation, and it can wax and wane as well too. And let's think about that. The physical effects of the falling estrogen can also undermine sexual motivation. If you're hot and sweaty all the time and you can't sleep and you're feeling a bit, body conscious, your desire is going to wane as well, because you just don't feel very sexy at that point, okay? Other things that can impact your desire, conflict, medical problems, and we'll talk about a bit more about that as well too, and cultural issues. So if that's desire, then arousal are the physical changes that the body undergoes in anticipation of sex. And then the experience of sex itself will be the response, the pleasure, and your orgasm. So arousal, like we spoke about, the physical signs of readiness: blood flows to your genitals, the vaginal lining becomes moist, the vagina grows longer, your breath speeds up, your heart rate goes up. Desire often triggers arousal, but for many in menopause, desire may follow arousal, particularly because of the hormonal changes and vaginal changes, okay? The vaginal dryness and atrophy can cause arousal to take a bit longer to achieve. So a common thing, my patients tell me is, it just takes me a long time to get wet or to get aroused. And that can be partly because, blood supply is decreased, the vaginal dryness is then there's atrophy, because less estrogen results in less blood circulation to the vulva, the clitoris, and the vagina. There's also decreased response and pleasure. Again, possibly with hormonal changes and the reduction in sensation and pleasure. This may affect orgasm. Orgasm may be less intense and longer to achieve. If you don't enjoy sex, even when you have it and it's uncomfortable, you can't orgasm, it's dry, it's going to affect your desire as well. And so all the factors of the sexual response sort of interplay and sort of affect, your experience of sex itself. The next one of the other problems we want to talk about really is pain with penetration So the dryness and thinning of vaginal tissue can cause people to not enjoy sex. Some women report dryness, tightness, severe pain. They have soreness and burning even after sex. So after sex, they still feel like they've got to pee because it just feels really sore and feels really burning. When you think you're going to have painful sex, it can make you pretty anxious about having sex again. So then can trigger performance anxiety, worrying about what's going to happen next. Is it going to be painful again? Am I going to enjoy it? Do I have to bear this again? We can also have problems in our partners. So also men do have changes in their bodies as well. So erectile dysfunction in the male partner can be a problem. I just want to say that, sexual problems are common in perimenopausal and postmenopausal women in about a third to half of them. So if you're having any of these problems, you're not alone. This is common. We know this happens. And the good thing is there are things we can do about it. Other things that can cause sexual problems, we've spoken about the vaginal discomfort, pain in the vulva or pelvis, things like urinary incontinence. First thing first, this is not a normal sign of aging. If you're leaking urine or you can't control your pee, I know a lot of women accept that and say, I'm getting old. It's not a normal sign of aging, and there's help available. Whilst leaking urine will not stop you from having sex, it can affect your self-confidence. Leaking urine during intercourse can affect up to a quarter of women. So like I mentioned, this is not a normal sign of aging. If it's bothersome to you, please see your doctor. There are things that we can do to help with this as well. I spoke about hot flushes and your quality of life. If you're hot and sweating, you're not sleeping, you're not going to want anyone to touch you in bed. You don't want to be close to your partner because you're so hot. And it just creates like a negative cycle. Illnesses and medication. And this is actually a very big part of sort of things that can affect, our sex lives. Diabetes can dampen sex drive, heart disease, high blood pressure, and the drugs that are used to treat them. Some of our beta blockers, the diuretics, can cause a decrease in our sexual enjoyment. Cancer can affect a woman's perception of herself. There are also changes that come from the medications they're on. A lot of the medications for some of the cancers work against estrogen in your body. If you have radiation, chemotherapy, all that can affect your quality of life and the tissue function of your body as well too. Arthritis as well too. If you have arthritis, that can affect your response to sex, your enjoyment of sex, and your physical ability to actually have sex in certain positions and things like that. Some of the meds that can cause problems with us, the medicines for cholesterol, and in my perimenopausal women, so women who are not quite menopausal, but in that stage, some women report that birth control can dampen the sexual response as well too. Mood changes can affect our sexual response. While menopause doesn't cause clinical depression, we do know that mood changes are observed in about 23% of perimenopausal and postmenopausal women. One of the medicines, a very common medicine that we use to treat depression, are antidepressants. Many of these drugs, though, can cause a lot of sexual problems, including decreased libido. Some can cause problems with arousal and some with orgasm. A very common complaint is decreased libido. A lot of our medicines are sort of culprits: Prozac, Zoloft, Celexa. All these medicines can cause sexual dysfunction in relationships. Some of them not so much, and we'll talk about them as we go along the talk. Substance abuse and sex. Alcohol in excessive amounts can dull the central nervous system, can trigger hot flashes, disrupt your sleep, and cause fatigue. Sleep disturbances, stress, a lack of privacy. Other problems are poor self-image, changes in your partner, relationship issues, and abuse. Kelsey, Dr. Steele, did you have anything you wanted to chime in at this point, or any questions that are pertinent to us so far?
Just slightly, is that sometimes people experience mood symptoms throughout menopause that are not necessarily related to depression and anxiety, but a lot of irritability, impatience, frustration can be a huge one, right? Bodies are going through changes, and it can be really frustrating to feel as though it feels out of your control, right? And maybe partner doesn't understand, or maybe you're trying everything you can and it still isn't changing. And that can be really frustrating too. And so part of the process is really trying to have a little bit of acceptance with, okay, my body is going through changes. And although, medications can help, Part of that too is kind of that thought process and behavioral patterns that can be implemented to just help ease it. Won't take it away, because bodies are going to do what they're going to do, but really trying to engage in something calming or something pleasurable just to help bring down that irritability from that 10 to, let's say a 5. Because when we experience that, that's when we can have those more sleep disruptions, the interpersonal conflicts, or even just the romantic difference of, ugh, get away from me. I don't want to talk to you right now or sleep with you. So just being mindful that that is also a very common emotion. And, it's as important to work through that as well.
Excellent. Thank you for that. And so now we're going to talk about some treatment options. And I've broken this down in sort of segments of like the sexual problem and the treatment option. And the first thing we're going to talk about right now is vaginal dryness and atrophy. So we already spoke about what this means and why it happens and the hormonal changes in our bodies. So one first thing is regular sexual activity or stimulation can promote healthy vaginal health and blood flow. For my patients and for anybody, having problems with vaginal dryness, there's a couple of things we can try. We can try vaginal lubricants, and these are over-the-counter lubrication that can help relieve temporary dryness before or after sex. We can try vaginal moisturizers. These are like sort of more long-lasting for long-term relief from dryness. You use them a couple of times a week as well too, and that can help as well. So while your lubricants are sort of on demand, before and after sex, a moisturizer will just help you feel less dry and less irritable as the days go on. And these are available over the counter. I do have a list of different ones then, and you can buy any of these things. There's no sort of real like randomized studies on, how good one is above the other, but we do know that compared to the others rather, but we do know that they are good and can give some relief for women who don't want to pursue any hormones. They just want something sort of like no hormones, but that can give them relief. Some of them have hyaluronic acid like Reverie, and that's also, it's known to sort of attract moisture to the vagina. And you can sort of play around and try which ones you feel better. If you do come to the Lebanon office, I do have samples of lubrication and moisturizers that I can give out to you. I always give my patients a little goodie bag to go home with if they want one. A very common moisture lubricants that everybody uses is KY jelly and Astroglide. They're not on my list just because they sometimes contain things that irritate some women. If you're okay with them and they don't cause you any irritation, that's fine. But some women, KY jelly is pretty popular everywhere, but it can cause a bit of irritation for some women. So I say to everybody, if you want to try a new substance, a new lubricant, do a patch test. Just put a little on somewhere in your skin for like 24 hours. See how you feel about it. See if you have any reactions, if you're okay with it. And if it's okay with you, then use it in your vagina. Other things so those are sort of over-the-counter non-hormonal things we can try. Then we talk about sort of hormonal things. We just spoke about, we lose estrogen in our vaginas and vulvas, and that's what causes a lot of these changes. So what do we do to help this? We can replace this. Okay, we can give you low dose vaginal estrogen. They come in various forms. They come in creams, they come in rings, they come in tablets. And no, they will not cause you to have breast cancer. And that's a very common concern that a lot of my patients have. And, these are not the same thing as the systemic preparations. They're not the same as the patches or the gels that have estrogen that go all over the body. They sort of act very local acting. And even when they're absorbed, the levels of estrogen absorbed in the body just reach the postmenopausal levels. They will not exceed levels of that amount. So they're very, very safe. And, they're recommended by all major governing bodies for treatments of sort of like vaginal dryness, vaginal pain with sex, Like I said, there are various forms. There are suppositories that have a bit of lubrication in them as well. There's a ring that you keep for 3 months. There are pills and there's the cream. So, you can play around with different ones, speak to your providers about them and try which one of them it works for you. If you're having more than one symptom, so it's not just your vulva and vagina that's dry, but you're having flushes and sweats and you're just very uncomfortable, then we can give you estrogen as well. And that's sort of more systemic, meaning it goes around your body to be absorbed. And now you can talk to your doctors about that. Okay.
Dr. Bashwa, I actually have a couple questions. A couple are actually related to estrogen. How many years do most women take estrogen? It looks like they have it for maybe some sleep and mood, and just curious kind of what's a normal range of use.
So vaginal estrogen can be taken forever because we're just replacing what the body is lost. So that's vaginal estrogen. Now, systemic estrogen, so like the patches, the pills, the gels in your skin, that's a bit different. And really, it just depends on the woman. So the NAMS is the Menopause Society and the official governing body for, like, menopause and hormonal therapy. And the stance is, in a woman who's sort of, a younger woman, so we women in their 40s and 50s who are less than 10 years from menopause and less than age 65, it's pretty safe to initiate and start them on hormonal therapy, okay? And you can carry on until the symptoms get better or resolve or get better. After sort of 10 years of use, or like age 65, then what you want to do is have a discussion with the patient about her level of risk, what are how is her general health, her cardiovascular health, diabetes, her bone health, and just weigh up the risks of that versus continuing therapy. So beforehand, we used to sort of stop people after, maybe 5 years, 10 years, but now actually it should be a conversation between you and your doctor, weighing up the risk. Can you maybe go down on the doses? Actually, what are your symptoms still ongoing? If hot flushes are not so bothersome for you, maybe it's just vaginal dryness, then maybe try that instead. If it's just maybe sleep that's the problem, maybe try something just for sleep. But there is no indication to abruptly stop, systemic estrogen. It should be an individualized approach.
Okay, we have a few more questions. It looks like this is a really great topic. One person had said that lubricants are very easy to find. Can you buy a vaginal moisturizer over the counter, or are they only prescribed by a doctor?
They're over the counter, all of them. And I have a slide with pictures of them. All of them are over the counter. And, a lot of OB/GYN offices have samples as well too. These are all pictures from Google. The prices are on there. You just, any one of them. I have a list of, some of them, but they're all over the counter. And just also sometimes ask your primary care doctor, your OB/GYN, if they have samples too.
Okay. Is estrogen replacement usually covered by insurance?
Yes, it typically is. Now, there are different forms of estrogen replacement. So sometimes your insurance might cover one, another the other, maybe cover a pill versus a patch. But there are also other pharmacies. So like there's the GoodRx coupon card you guys may have seen that can help you get discounts on products. But there are also like other stores for vaginal estrogen. Mark Cuban Pharmacy, Cost Plus Drugs. If you Google it, it's like an online pharmacy that will sell vaginal estrogen estrates for $36 a month. You have to sign up yourself, and the provider, put in your details online, and you can send the medicine there, but that will cost you about $36. So insurance will cover, but if your insurance doesn't cover medicine, speak to your doctors, because sometimes it's just trying a different preparation of the medicine. So, and just trying different things out, but don't give up,
Okay, we actually have 3 more questions, if that's okay, related to estrogen so far. So, is systemic estrogen prescribed for perimenopausal women or just menopause and postmenopausal women?
Perimenopausal women, they're the best candidates. So women in your 40s, 50s, so women who are less than 10 years from menopause, are the best candidates for systemic estrogen. So perimenopausal women, you can still be having periods, and, but you're still having some of those symptoms like we spoke about, like, the hot flushes, the sweats, the dryness, and you're an ideal candidate then for systemic estrogen.
Okay. And for those individuals that are unable to use estrogen due to prior cancer risks or other health conditions, what would be recommended?
So first, that's a very good question. Thank you for that. So when we speak about like moisturizing those lubricants, and I have more about lubricants and which ones you choose and why. First of all, exhaust, the lubricants and moisturizers. Silicone-based lubricants tend to be more slippery and long-lasting, so that tends to be more comfortable for people. Now, if you have vaginal estrogen is safe for breast cancer patients, and I slowly say that and I hesitate because some of the breast doctors and oncologists don't completely agree, but a lot of the governing bodies have agreed that, because vaginal estrogen is only absorbed in the body in very small amounts, it is pretty much safe for breast cancer patients. So, and the levels that's absorbed in will only get up to like your normal postmenopausal levels. So with that caveat, we have to treat you as a patient. So no decision should be made without the approval of your oncologist. So if this is something, that you want to try, and you've tried the lubricants and you've tried the moisturizers, and and you're still having a lot of discomfort, then it might be worthwhile bringing up your oncologist or your GY and saying, I have breast cancer or whatever cancer you have, particularly the hormone dependent cancers. So, and just saying, but I want to try something else. Vaginal estrogen is a good option. There are different preparations of vaginal estrogen. So some are absorbed a little bit more than others, and that's something you can talk about. So, but the studies have shown, at least, that it's probably okay. But again, I say that knowing that, you have a multidisciplinary team, and that not every provider might share that opinion, but certainly, ACOG, NAMS, the official statement from NAMS is there's not a long-term data to officially recommend it. But if you read the paper thoroughly, it does say that the levels are pretty low and probably can be used. So I think it's certainly worth discussing. And there are a lot of oncologists that will let their patients have vaginal estrogen, maybe not all, but certainly, like I said, that plan should be individualized to yourself.
Thank you so much. It looks like I'm going to kind of answer this just based on what you had said. Is it sounds like if you are inquiring tonight to Dr. Bashwa about some like specific medical concerns, or wondering if it's appropriate for you, strongly recommend talking to your individual doctor or your care team so that you are able to get that information from somebody who knows your health history best, with things like very specific medical conditions, blood clots, things like that, just to kind of be referred back to that medical provider. Dr. Bashwa, somebody was hoping that you could repeat the pharmacy name.
Yes. Cost. It's Mark Cuban, Mark and Cuban, a Cuban, I forget, Cuban. That's the name of the owner of the pharmacy. And it's Cost Plus Drugs.
Perfect.
I think Amazon actually also sells vaginal estrogen. And just going back to what you said about blood clots. So vaginal estrogen, again, has not been linked to increasing blood clots or cardiovascular risk factors, heart attacks, stroke. So vaginal estrogen, it's pretty much safe for almost everybody. So, this is something that you can really, push to discuss with your healthcare provider, push and ask them to reach out to resources. I'm always happy to see anybody by telehealth or, conference, just to like give you that information so you can take back to your own, provider and just saying, what about trying vaginal estrogen? But even if you have a history of heart attacks, strokes, blood clots, vaginal estrogen should still be okay for you.
Great. And then last couple, I'm going to put them together. It sounds like we're talking about estrogen for certain populations. And there is a question about what about estrogen in postmenopausal, and kind of tied with that, what are some of the risks of estrogen?
So again, postmenopausal women, like I said, it should be started within 10 years of menopause. So if you're postmenopausal 1, 2, 3 years, 4, 5 years, that's okay to start your vaginal estrogen. And if you're, and also less than age 65, what you kind of don't really want. So the risks of systemic estrogen basically went up in women that are sort of older. So, your 70-year-old women who you're just starting estrogen on. So you don't want to start it in somebody who's 70, who's never been on it. But if you started estrogen in your 40s and you are now sort of 60, 65, then a discussion about carrying on the estrogen is appropriate. But I wouldn't start, a 66-year-old or 65-year-old woman newly on systemic estrogen. Does that make sense?
Mm-hmm. Yeah. And are there tests or medical tests to determine what hormones somebody would need? Like how would, if somebody came to you, how would you as a provider kind of determine that?
So by your symptoms, like I said, in the very first slide, we spoke about the hormone levels do fluctuate, especially in the perimenopausal women. They still make estrogen. It's just sort of, sort of like, today it's high, tomorrow it's low. So we go by your symptoms. We don't really need to do a blood test. And sometimes patients want to check where they're starting from and just want to know. And that's okay if you want that. But it's by your symptoms. Now, if you had a hysterectomy and you don't have a uterus, and then so you're not sure where you are in menopause kind of thing, then sometimes we do blood tests, but it's mostly really just, are you bleeding? So if you're bleeding, still having periods, you're not in menopause yet. And if you're having the other symptoms like flushes, sweats, and your periods are getting more irregular and things like that, then you may be in perimenopause. So if you're menopausal and you have no symptoms and you go into menopause with no hot flushes, no sweat, you don't have any vaginal dryness, and then you don't need anything else. We spend about 40% of our lives in menopause. You don't need anything else. If you don't have any concerns or problems, nothing needs to be treated. But if they're becoming, and the first line treatment is always lifestyle measures as well too. But if this becomes more of a problem for you and you're just finding it hard to cope, and I always talk about quality of life. If your quality of life is dwindling or being affected, then we want to talk about actually how can we help it, because like I said, you do spend about 40% of your lifespan in the menopause, perimenopausal period. So we want to make sure that you are living your best life, you're living your best self.
So it kind of sounds like what you're saying, Dr. Bosch, was that first kind of looking at lifestyle to see if there's any changes to be made there, trying to improve with maybe some over-the-counter things. And if symptoms really persist, then talking to the provider about some type of supplement, such as estrogen, to kind of address the issues that are unresolved or still present.
Absolutely.
Perfect. Okay. I think we've caught up on all of the questions.
Okay. So we spoke about pain during sex, and I think we've touched about this as well too. But again, vaginal moisturizers and lubricants. If that pain doesn't improve, see your provider. Vaginal estrogen will help. We also have two other drugs that are not vaginal estrogen, and one is an estrogen modulator, is an oral pill. And if you have really bad vaginal pain during sex, this is medicines made specifically for that, really bad pain during sex. And sometimes I put people on either the Osphena, it's a pill that you can take, or something called Intrarosa, and that sort of goes into vagina, and that is basically like a DHEA, which is sort of in the body, in your vaginal tissues, breaks down to testosterone and estrogen, but that can really help with tissue health as well too. So just a couple of things to try. I think the main point I want to drive in is there's always something else to try. So if you've tried one thing and this didn't work, or you tried, don't give up. And if, once upon a time you tried and you're sort of, many years away from menopause now, and you didn't know these things before, or you were scared, or you were just worried about them, it's not too late. We can start again, we can try again. And I really encourage just to seek out, more information and just give yourself a chance, okay? So I wanted to just talk to you. So we've spoken a lot about, the moisturizers and everything. So other things, stop, smoking cessation, let's do that. And let's just talk about, so the moisturizers, I said, they can use them regularly for maintenance of vaginal health. They basically replace like vaginal secretions, and they'll bind to the tissues. Like 67% of postmenopausal women will use a moisturizer, and they can work pretty good compared to estrogen for vaginal itching, irritation, and pain with sex. They won't reverse the changes that have gone on, but if you don't want to use a local estrogen, they're a good alternative to try, okay? And lubricants are good for like pain reduction. They can also help with increasing sensation and pleasure during sex as well too. And just a couple of points with how to pick a good lube. So I think this is the slide for moisturizer. Do you have some for can you go to the lube side? Yes. Yeah, go back one slide. Which lubricants? So there are different types of lubricants. Some are water-based, so all-purpose lubricants. You can use them with all condoms and aids. Easy to clean, but they dry out pretty quickly. And so a common example would be your KY jelly. Okay. Then you have things like petroleum. So this is like your Vaseline, your baby oil and things. And they can't be used with latex condoms. They can leave a coating in the vagina or the rectum, but they can also irritate skin. So I don't really recommend those ones to use. You can also stain. Natural oils, coconut oil, avocado, olive oil, just get a jar of Crisco, whatever, those oils are great. Again, they can leave an odor. They're safe, they can use them safely in the vagina. They don't cause any irritation unless you're allergic to one of them. They can leave a coat in the vagina or rectum. The safety with condoms are a bit unclear. So whether, probably don't use them if you're going to use a condom, okay? And then we have the silicone ones. And these are like more slippery, more long lasting, pretty gooey, They're sometimes a bit difficult to clean, but you can use them with condoms, but not silicone based aids. They don't irritate the vagina and they're waterproof. So just depending on, so if if you have a lot of dryness and discomfort, then I like the silicone one for my patients. And I think the next slide has some pictures of some of them. So some of the water-based ones, Sklid, liquid silk, Good Clean Love. Good Clean Love is a nice one. And I have samples of that in the office. And then you have the silicone-based ones as well, Uber Lube. This is other ones on my right side. I don't know what you guys are seeing, but on that side. And the one in the middle is a hybrid of both water and silicone base. And just try them out, try one out, see how you feel. If you like it, get some more. If you don't, or just coconut oil. Most people have oil at home or can get that easily as well. Just try that out and see how you feel with that. So common things, again, avoid irritants. So some of them have things like glycerin in them that irritate, parabens, glycol. That can also irritate the sensitive vaginal tissue already, Like I said, silicone is most slippery and long lasting. If your partner has erectile dysfunction, try a water-based one as well too, And if you have like toys that you use or sex aids that are silicone, made from silicone, then try a water one as well too. So I think that's sort of what we wanted to speak about. Any questions about moisturizers or lubrication and anything like that? So use lubricants as needed to reduce friction, for sexual pain, for vaginal dryness, particularly for like the chemo patients in therapy, also for your younger sisters or friends or daughters, even after breastfeeding or during birth control, using birth control pills, you can be very dry as well. So it's something you can recommend. You don't have to be on it forever, but if your friend, sister, younger daughter, anybody's having problems with breastfeeding and things, just recommend a lubrication to them as well too. Okay.
Real quick, sometimes I get individuals that come in and they're trying to spice up sex life by maybe getting some flavored lubricants, just to, help things move along. And sometimes that can cause some irritation or have some reactions. Be very mindful of that, because even though it might taste flavorful or have that little sense of spice, it can kind of just disrupt, cause some irritation. And sometimes that can be frustrating when somebody's been trying to find something and can build to that irritation or frustration level that acts as a barrier to intimacy.
Absolutely. Thank you for that. And so that's sort of, about, pain, sexual pain, vaginal dryness. If you have any more questions about that, please, bring them in. And the next thing we're going to talk about is about low libido and then low sexual desire.
We have a couple questions about moisturizers.
Yes.
So moisturizers can be used several times a week, while lubricants are only used during sex.
You can use lubricants as on demand. So yes, during sex mostly, but on demand, they're just like short lasting things, but moisturizer designed for sort of like more long-term use. Mm-hmm.
Okay. And do you ever recommend using lubricants and moisturizers together?
Yes.
Perfect. There we go. One person said, how does Osphena work for pain, even though it's not necessarily related to lubricant or?
So it's an estrogen modulator. So it basically will essentially convert to give estrogen to tissues. So it's a pill that you take, but will help convert to estrogen. I'm sort of, simplifying that. But basically it's just an oral pill that will sort of modulate that and just give more estrogen in the tissues. Okay. Not the exact mechanism, but just to sort of make it simple. So that's what it will do.
And Dr. Basho, do individuals who have had hysterectomies or other surgeries, do they make estrogen? Do they have increased risks for using estrogen?
So So that's a good question. So estrogen is made in your ovaries. So even if you have a hysterectomy and you have your ovaries, you can still make estrogen. As you can also make estrogen in adipose tissue. So you can make them in your fat cells as well too. Okay, and they're different places, and your body can make hormones in a couple of places. So you can use estrogen, even if you had a hysterectomy, because like I said, it's made from the ovaries. So did I miss the question, or did I?
Nope. And what about those individuals that no longer have their ovaries?
Yes. So again, so that's a very big topic, and it just depends on when you lost your ovaries. So if you were, younger, and because of cancer, whatever, you lost your ovaries in your 20s or early 30s, then we actually want to replace estrogen for you at full value. We want to give you a physiological range for a premenopausal woman. So we would give you higher levels of estrogen, okay, like sort of like the amount found in the birth control pill, if that's that kind of thing. We want to give that replacement. The estrogen in that we use for menopause is much lower than that in sort of birth control pills. So if you lost your ovaries when you were much younger, then we want to give you estrogen, because estrogen is important for your health, for your bones, for sex. If you lose your ovaries when you're younger, it does have a lot of effects on you. So we want to replace that estrogen until sort of you are until you'll have gone through menopause, to around about your 50s. If you lost your ovaries, in your 50s or late 40s, and you don't have any symptoms, from lack of estrogen, we don't need to replace it, but we can. So if you had a hysterectomy, at 52 or 48, and you said, take everything out, I don't want it, then, but you were okay, we don't necessarily need to replace that. It's sort of for younger women. So if you went through menopause before the age of 40, or you had your ovaries taken out sort of at that kind of time, then we kind of want to make sure that we give you back estrogen. Okay, but yeah, so it just depends on when you lost your ovaries. But typically when I do hysterectomies on women, I tell them, even if you're menopausal, we think the ovaries can still help with sort of cardiovascular health till about even 65. So I don't necessarily counsel my women in their 50s to take out their ovaries. And we talk about a risk-benefit ratio, but they still have some function, but not to a level that they need to be replaced for to protect your heart or things like that. But and there's no recommendation for estrogen replacement for cardiovascular protection. But certainly the younger woman, yes, we would give you back physiological. So in a woman who's not menopausal, we want your estrogen levels to get back into that range. Mm-hmm.
Mm-hmm. And it looks like there was a question about the breast cancer and not a candidate for the hormone replacement therapy. And as Dr. Bashwa mentioned earlier, really talking to oncologists in your medical team, because some of the vaginal estrogen, I believe she said, doesn't really show a higher level of or dangerous levels. So really going back to those medical providers and advocating for different avenues for estrogen or replacements for comfortable sex.
Yes, you can just talk to them about it, or talk to them about, intrarosa as well. Again, that is converted to hormones, but the studies have shown, at least for some of them, the creams are a bit more variable in the level of absorption, but certainly for the tablets, the inserts, the levels are sort of comparable to in the postmenopausal range. So it's just a discussion, between your multidisciplinary team, saying, hey, this is what I've heard, I'm struggling, I've tried all this already. Are you okay if we take it a step further? And then, going that way.
Thank you.
So let's talk about low libido now, because, that's a big topic as well too, Let's talk about low libido and low sexual desire. Dr. Steele, please chime in at any point there. So we're talking about first and foremost, like, we've spoken about, examine your relationship or your situation. What's going on with you? Sex is very multifactorial. Everything plays a role. There isn't sort of, you can't have sex in isolation, divorced from your feelings, your social circumstance, where you are at the moment. What are your turn-offs? How can you address them? And then medications that can curb desire. We spoke about antidepressants and blood pressure medicines and birth control pills. And there's a whole slew of medicines that can impact or affect so and it may be worthwhile talking to your provider about lowering the dosage or switching to alternatives. Like I said, a very big culprit are sort of SSRIs, and I give common examples of them. Medicines that are used for like antidepressants and things, and a lot of them can affect sexual function. So, just medical history, diabetes will sort of, lower your sex drive as well too. And just, addressing some of the medicines and things like that. Okay. And then what do we have that we can use to treat? So in a postmenopausal woman, there are no FDA approved products for treatment for low libido. However, we do know that for some women, testosterone replacement can help with low libido. And this is tricky because then everyone starts asking, well, so what level of testosterone will mean I have low libido? And there is no level of testosterone that will indicate that you have low libido. Women still make testosterone even from the ovaries, even after they stop making estrogen. Some women have low testosterone levels, but their libido is fine. So it doesn't correlate. So, there's no level at which your testosterone is too low and therefore you must have it replaced. However, there are studies that have shown that giving you some testosterone can help your libido level, okay? And so it's not going to be a dramatic effect, but it can make things better. So, and we use basically the male testosterone products. Men have a lot of products available to them, and we just use like 1/10 of that dose, and we just monitor your testosterone levels, and we give it about 6 months, kind of thing. If it's working, you can probably try for about 6 months or so. There's no long-term data on it, but that's certainly something you can try. Wellbutrin is another drug that is typically used for mood disorders as well, but actually has been shown not to necessarily decrease libido, and can sometimes make it better actually. So if you're on an antidepressant, for example, and it was really affecting you, you could try switching, and again talking to your provider about trying Wellbutrin, or if you wanted to stay on the one you were on, maybe adding that on as well as an adjunct. Can try that. There are other buspirone as well, Buspar, other medicines, trazodone, that you can try. Again, none of this are government approved for FDA funding, but we can try them. There is another drug, and you may have seen the adverts for it, called the pink pill, Addy, and it's FDA approved for premenopausal women in the United States. However, they did do studies on postmenopausal women as well, and it was also beneficial. Now in Canada, it is approved for postmenopausal women, so again, not FDA approved, but if it works in Canada, it probably does work in the United States as well too, so I think it's something that, again, you can speak to your provider about. And again, you just try it for about 8 weeks. If you respond, you respond. If you don't respond, then you don't respond. There are some reasons contraindications to Addy. And again, having a detailed history about you is a good place to start from. But it's like its adverts are very popular. It's a pink pill, and like I said, it's not FDA approved for postmenopausal women, but they did do studies on them. It works, and I do give it to postmenopausal women as well too. And then yoga as well too, actually, has been shown as well to help the libido and sexual desires, and also there's sex therapy and counseling.
So we do have one question before I kind of jump in with the other pieces. Are there herbal supplements that can help with libido?
So there have been no studies or trials that have shown any herbal supplements to help with, libido and things. So there's none I can recommend. Everybody, my view on supplements is, everything is a medicine, even if it's called a supplement, it's still a medicine, and some of them are not regulated. You're not quite sure what goes into them. If you are going to try something, just double check your healthcare provider and don't buy something really expensive. Like I said, there's no supplement that has been shown to, really make a difference. So if it's something cheap and it's not, and we can trust the list of ingredients, then probably can try it, but I wouldn't go spending like, $50 on a bottle of, snake oil or something,
Sounds like people had questions about how yoga helps with libido.
So I think it's sort of more sort of like the mindfulness of the exercise of yoga. It teaches you to concentrate, focus, because sex is intentional. So, it helps with the muscles as well, to your pelvic floor, the posture and the libido, and relaxation techniques as well too, but also focus on the mindfulness, the focus of yoga. I think that was an interesting one of my research. It's like, okay, I did not know that before, until recently. So,
I would also add, I didn't read specific what the research was, but what we do know is that individuals that we're not always in tune with our bodies, which I know that sounds really odd as we're talking about symptoms as people go through menopause and, experiencing and trying to understand what's happening. But during sex, oftentimes what we find is that people's bodies will actually respond, but not be perceived. Meaning, if you are having sex and thinking about the grocery list and taking the dog for a walk and how you don't really love the smell of your partner's breath right now, then you could actually be feeling a lot of pleasure and not actually perceiving it, because that's not where our mind is at. Yoga is the practice of really putting those two things together, being really in tune with your body, really recognizing what's happening, those limits, what they are. And so I imagine that probably crosses over very well with sex, of really learning kind of what those limits are for people, and what you're feeling.
Yes, there was a study in 2009 and it was published in the Journal of Sexual Medicine, and it just showed that, there was a beneficial effect in actually desire, arousal, lubrication, orgasm, satisfaction, and pain. The biggest improvements were in women 45 years and older. And it's probably because, actually, Dr. Steele mentioned the relaxing effects. You focus on sensation, the pelvic strengthening effects of yoga, your improved self-image as well too, from engaging in exercise, and a mixture of things as well too,
Mm-hmm. Okay. So we did get a couple questions. I'm going to probably kind of talk a little bit about the sex therapy piece when it comes to behavioral health. So I have to make the disclaimer, I am not a sex therapist quite yet. I am a clinical psychologist though, with that clinical interest. So I do work a lot with sexual health and sexual dysfunctions. So just that slight, almost. In terms of sex therapy, there's so many options. And, I imagine that it can be really difficult to talk about, especially, talking about likes and dislikes and self-stimulation habits and what is included in sex. It can be very personal, but it can be very helpful. Some people don't always think about what is pleasurable and what is satisfactory. We oftentimes think about what we don't want. And that's not uncommon when people come into my office and I ask them, what is your, what's a fantasy of yours? And you may not have one. And so we don't really think about what type of sex we want to have. We just know what type of sex we don't want to have. There's a lot of different forms of therapy that can be used. CBT is very helpful. A lot of therapists are trained in that. There's a lot of sex therapists that are certified that can help with pain levels or trying to understand where the pain is. Even referrals to other places like physical therapy to help with that pelvic floor and to help with that sensation or that rigidity there. Okay. There's also sensate focus. So what type of touch, how do we improve like safety, if you will, right? Kind of a lot of times people will tell me, we're going to start and within 2 or 3 minutes, we're having penetrative intercourse. And a lot of times it takes a lot longer to feel, desire, to feel aroused and to actually want to engage in penetrative sex. And so really recognizing what's happening in the body, clitoral stimulation with any types of toys or lubricated vaginal massage can be very helpful with trying to help feel a little bit more aroused rather than automatically jumping into it, if you will. Okay. This can also include trying different things. So what do you want? What do you feel comfortable sharing with your partner? And what does that look like with you? That does cause a little bit of vulnerability with, if there are some body image or things like that. But also understanding what the setting should be like for you. If you're very uncomfortable, let's not have sex at 12 o'clock with all the lights on and the blinds open. That might feel uncomfortable and it might not be satisfactory. And so really recognizing too that there are ways to create sensuality that can really increase a desire to want to engage as well. Okay. A couple people asked what CBT is. So CBT is cognitive behavioral therapy. It's a type of therapy that really connects thoughts, behaviors, and emotions to help understand. So it takes a situation, analyzes it, and then tries to understand, are our thoughts accurate? Are we behaving in a way that aligns with our desires? And then kind of behavioral strategies to help work through it. So it can be very effective. It can also be very effective with trying to cope with menopause, even outside of sexuality, just dealing with some of the concerns that arise. Okay. Does pelvic floor strength have an effect on orgasms? I'm not sure I know the answer to that, actually.
It depends, I guess, on what your pelvic floor is doing in the first place and your underlying pelvic floor health. And just going back to that, I spoke about a lot about sexual pain, and I forgot to mention pelvic floor therapy. Yes, and dilator therapy. If you have very painful intercourse, and even after we start treating you with medicines and vaginal estrogen and all the things I spoke about, it's probably not a good idea to just jump right into it if you have gone years without it, or even if you wanted to start, it may still be very uncomfortable. So dilator therapy is just, and it's practiced in different ways, but essentially getting a set of dilators of different sizes. So, very small, to maybe about the size of like an erect penis, essentially. And just, putting some lubrication on them and just gently insert into the vagina, for about a few minutes, a couple of times a day, just to gradually accommodate, sizes. And really, if I have a woman who's just, dipping her toes in, and she's got a lot of pelvic pain and things like that, then first of all, everyone should go to pelvic floor therapy, after childbirth, starting from when you were much younger, But, certainly they can help you sort of learn to relax the muscles, learn to accommodate the dilator therapy, learn to feedback. Sometimes because of fear, women have vaginismus. You've had your pelvic floor remembers things, it remembers it. You can feel anxiety and carry anxiety in your pelvic floor. So if you have a painful sexual encounter, the next time you're going to want to do that, your pelvic floor is like danger, danger, danger. So you're going to tense up in anticipation of pain. And when you do have sex, it's going to be even more painful. And that cycle continues. Your pelvic floor muscles are tight, so pelvic floor can help with sort of like, relaxing those muscles, and teaching you that you have control over your body, but also helping you very gradually with dilator therapy. So the answer to does it help you orgasm? Well, it'll depend on what's going on with you, what's going on with your pelvic floor. If just relaxing enough of your pelvic floor to sort of enjoy it, and we have different types of orgasm: clitoral, vaginal, cervical, uterine, so if you're a person that has that can have a cervical orgasm, but you can't accommodate, anything in your vagina because it's so tight, well, when you're eventually able to relax or accommodate, an erect penis or toys or whatever, then that may open up some pleasure for you in that sense.
Kind of speaking off of the anxiety piece, therapy, if you're open to that, can be very helpful, not just pelvic floor physical therapy, but also behavioral health therapy. Because what we find is I've helped women who feel anxious about going up in sizes with their dilators. Maybe the first one is okay, and then when it gets to the second or the third one, that anxiety comes, and it can be really impactful because the vagina will tighten to where they're unable to insert. And so really working on that mindfulness or strategies to help relax is going to be very important, so that so the vagina becomes relaxed and you're able to insert and allow for that to happen. A lot of people experience anxiety when trying to do that. There's also, aside from dilators, so that can help with, penis insertion and feeling more comfortable and decreasing that pain. If there is a penetration depth problem to where it feels very uncomfortable, there's also devices for that. One is called the O-Nut. It is wonderful. What it has is, it is little silicone, but they kind of look like little donuts, if you will. And you can personalize it to your partner. So if it's just a mild penetration depth that, where he feels uncomfortable, you can place 1 or 2 on his penis. And so it actually decreases penetration depth. And I think there's up to 5 in the kit, or, the one that you order. And so it can really help in terms of just decreasing that so that you don't experience that much pain. There are a lot of things that can help just with the different pain. And so if it's not necessarily pain and you're just like, I don't really want to have sex, that's okay too. Sex is a quality of life. And so a lot of research suggests that individuals that are not engaging in sex can experience more kind of like mood symptoms or relational problems. And that's not to say that sex solves everything. It doesn't by any means, but it does release oxytocin. It can release, dopamine for that reward system. And so it can shift our body in that way to release hormones that maybe aren't always released, especially if we're not connecting with our partner. So really trying to be mindful of that as well. Mix it up too. Try new things, try new positions, try new activities. Right now we are in a society that is a little bit more accepting of different types of things. Talk to your partner about what might be helpful. Talk to somebody, whether that's a friend, whether that's a therapist, whether that's your OB, GYN, somebody to really help get some ideas, because there really is a lot out there that can help. And a lot of us want to. That's why we're doing these chats, so that we can provide a little bit of information to help everybody feel as though, wherever you're at on the spectrum of wanting to have sex, it's okay. And there are people out there that want to help if you're distressed by it.
Okay? Yes. But Dr. Steele's point is completely valid, where it's only if it's distressing. A lot of couples do not have penetrative sex, or they don't have any sex whatsoever. And if it's not distressing for you, you are still fine. You are still normal. That you don't have to have sex if it's not distressing for you and your partner. And just a couple of practical tips we're talking about, if you have arthritis, for example, maybe try sex after a bath, even for just in general, just increase after a bath, just increase blood flow. Maybe try a waterbed, I try it on pillows, just different. There's always a way around everything. There's always a way to make things less uncomfortable, less painful. And, also just talk to your providers about it. We want you to ask, and sometimes it may be a little awkward for everybody concerned, but it's not because they don't want to help. It's maybe because they feel like they don't want to make you feel embarrassed about it. But most people are able to point you in the right direction, even if they can't give help. And you're not alone in these problems. A lot of people have the same problem. So just talk to your providers about it, and if they can't help you, they should point you in the right place. So I'm going to talk about arousal difficulties. And again, it's topical treatments for vaginal dryness and atrophy that we spoke about, but also vibrators. Vibrators can improve blood supply, to your clitoris and things like that, your genitals. So, and also just improve your satisfaction and pleasure during sex as well too. So if this is something that is permissible within your relationship, then it's certainly a way to also because we did speak about, it can take a longer time to stimulation and arousal. Okay, so sometimes things like vibrators can help you get there. Okay, also teach you what works for your body. As your body is changing and going through all these changes, and your partner as well is changing, then maybe some things are more pleasurable than others. And what maybe was your go-to is no longer your go-to, or due to physical adaptations, nerve damage, whatever it is. You kind of have to try and figure out what works for me now, what is good. There are a lot of people in the 90s and above, they were having a very active sexual lives, So I had a patient who told me she was in the 90s and she had a very satisfying sex life. So if this is something that is bothersome to you, then please, there's information out there, and there's help out there as well too. Again, we spoke about Wellbutrin can help with arousal. Libido probably more, but that, and sometimes we try like Viagra, like drugs, just to improve flow to the clitoris. Again, these are not FDA approved drugs. Men have a lot of more drugs available, and we sort of just piggyback off what men have, but because we know that there's evidence that it works for them, so we can try things like that. And again, yoga still again is a nice little wonder drug that we can try. Okay.
Just to play off of that is that there are expectations that sex will shift to. And so expectations of it might look a little bit different, but that doesn't mean it's bad. And that's okay. The other part too is that we will become satiated because we're humans. I love pizza, but if I eat it every day, I'm not going to want it. So if one thing feels good one day, try really hard not to get frustrated that it might not work the next, because our bodies respond differently. What was exciting, during one engagement or experience may become predictable and then become, like, okay. Really quickly, so it looks like people are interested in finding dilators or ONUTs. I believe ONUT has a webpage that you can go to and order directly off of there. Dilators you are able to find, I'm pretty sure, online.
Amazon, online.
Amazon, yeah. I'm going to answer a couple questions, but I am going to propose something. It sounds like we have a lot of questions. It sounds like there is some interest, and we still have a couple topics to cover, I think. Did we cover all of the topics, or?
The most of it was just sort of like a more behavioral advice and things. So I think we can take questions and interplay with them. It was just more about self-counseling, the PLIS model. That's what we had. So I was going to let you sort of take the lead on those topics. So it's up to you.
Okay. Now I know that we were originally scheduled 6:30 to 7:30. I'll kind of do a poll, if you will. Would everybody like to continue for a few more minutes, or is anybody interested in kind of like a part 2 to kind of finish up the discussion, maybe for like April, in terms of some of the behavioral health pieces or arousal and things like that? While people answer, a couple people asked about pelvic floor. Is it prescribed through the OBGYN?
Anybody. So your family doctor, your PCP can also prescribe pelvic floor therapy. So typically a lot of places have under physical therapy, and if you specify under that you want pelvic floor therapy, then you can get, but yes, you can also self-refer actually. So if you also just refer to PT and then just specify you're looking for a pelvic floor specialist, we have a couple of excellent ones in WellSpan. Again, but please, and if you also struggle to find somebody, even if you're not a WellSpan patient, you can also reach out to our office and I can provide you with a list. Okay.
And then, so it kind of answers that as well, but maybe not. Is urogynecology one provider that you'd be able to see for a pelvic floor exam?
Yes, but your OB/GYN probably can do a pelvic floor exam, and if there is a problem that needs to be addressed by urogynecologist, so urogynecologist is sort of a specialist, so yes, you can go see them, but perhaps maybe your OB/GYN first as a first port of call on what you think your problems are, and then they can refer you on further if you need further help, yes, but you can go see a urogynecologist.
Okay, perfect. So it looks like, Dr. Bashwa, we are getting a really good mix of people would like to continue for a few minutes, or they're open to a part 2. I'd say that, why don't we go for a few more minutes, let's say maybe like 5, and answer any remaining questions. And then we will also try to set up that second one for behavioral health in terms of, answering some questions about moods or how to kind of like spice things up if you'd like.
Absolutely. Absolutely.
Perfect. Okay. Are there specialized gynecologists? Is a question.
Yeah. So within OBGYN, so OBGYNs are generalists and they cover full spectrum OB and gynecology. And then within that, you have subspecialists. So you have a GYN oncologist who does treatment of GYN cancers. You have a urogynecologist, so she does sort of like pelvic floor, urology symptoms, within sort of in a woman essentially. You have a minimally invasive gynecologist who sort of do like like the robot or laparoscopic surgery, they will deal with difficult cases of like endometriosis or difficult myomectomies and things like that. Now, to note that a generalist can do all of those things as well. So there are some generalists that do all of those things, but you then have some people who do specialize and go even further into those things. So there are specialists. It depends on what you're talking about, but a lot of times your OBGYN can do a lot of those things, or maybe, some OBGYNs do a lot more of one thing than the other. So yes.
Okay, perfect. Looks like we're all caught up on questions. I believe we were going to talk about the Plicit model a little bit. Dr. Bashua, would you like to do that, or would you like me to?
So you can do that, just sort of like in physical terms of patients. So we've said, you've got decreased for women and men, decreased lubrication, increase your time for stimulation. And for men as well, too, they can be decreased rigidity, increased time for stimulation. And also get your partners to get help as well. Sometimes, in a less satisfying sexual relationship, it's not necessarily the female partner, sometimes it could be the male partner. And encourage them as well to get some help. See the urologist, warm baths, like we said as well, to changing routines and position and other positions like that too. But then, yes, that Dr. Steele, we can, take it away from there.
So kind of what we talked about as well, kind of just going off of that, is that when we are trying to assist with any type of sexual concerns, whether that is decreased libido, pain, things like that, it is helpful to really fully understand the problem. And sometimes it takes a few, I would say from a behavioral health perspective, it would take a few sessions to really understand kind of the trajectory of what that was. And so with the Plicit model, oftentimes some sex therapists are kind of trained in what this looks like to be very specific, because it can be more helpful. And so with that being said, trying to have like not only just that understanding, but the specific pieces of what's going on. So position wise, are there things that are causing pain that are not necessarily biological, but more environmental? So is that bed? Is that, needing to put pillows? Is that trying different types of positions, things like that, that can be really helpful. A lot of people also, and I don't mean this disrespectfully in any way, is that sometimes women also don't know quite a lot about their body. And so really having the conversations, not only about just anatomy, but also how things kind of interact during sex, or where pain is specifically, can really help understand some of that. Because maybe somebody says, well, intercourse is really painful, but then we really we're able to narrow it down to, maybe it isn't actually in the vagina, maybe it's in the perineum, and what that looks like, and how do we reduce that pain. So I mean, it's such a big topic that I think a lot of people want to talk about. And the normalization, like Dr. Bashua said, a lot of people experience these concerns, and it's normal and it's okay. Right? There's no shame. There's no embarrassment. Sex is just like any other part of your health. It's important to talk about. It's important to find a provider that you feel comfortable talking to about some of these concerns. And if there isn't, from a behavioral health perspective, sometimes that impacts somebody wanting to continue to talk to somebody else, and really trying to work hard to find somebody that you do feel comfortable with, because there are a lot of solutions. There are a lot of people that can kind of engage in problem solving to help. either in that brief treatment or in more outpatient treatment or certified like sex therapy. Okay. Let's see here. I don't know if we really have any more questions. If you are able to see your screen, there is a list of providers that are in the field that can, that can help, most of which are all medical. I think I'm the only behavioral health provider on there, but I am within the system. So if there's any questions or anything, please feel free to reach out. We're definitely happy to help in any way. We hope that this talk was helpful. We appreciate all of your interactions and questions and comments. We hope that this was helpful for you. Dr. Boschway, any last words or comments?
No, first, just, like I said, we want you to live your best midlife. WellSpan is very dedicated to ensuring that women live their best midlife in all ramifications. So if you have any questions about anything about midlife, and please let us know. If you have any questions about sex is such a broad topic, and I didn't cover everything or talk about everything. Reach out, let us know what you want to hear more about, what you wanted to see, and just live your best midlife. And thank you so much for the privilege to share information with you today.
Thank you. I think that completes for tonight. Go forth and have wonderful sex if you would like.
Yes.